Summary of complications following cardiac infarctions. We have already discussed some of these complications, but again, this is a brief summary of everything that can happen following an MI. Complications can be very extensive. As you can see, this list is pretty long. And then on the right-hand side, I was also able to give you a few more that I haven't listed on the left side. But in this brief summary, we will focus on the cardiogenic shock, pulmonary edema, and cardiac tamponade. And you're welcome to explore these other complications, or at least think about them, and maybe ask me more about it in class. So in terms of pulmonary edema, the definition says that it is simply accumulation of fluid in the alveoli. And why does it happen? Again, this is the result of a myocardial infarction. When the pump fails and is unable to pump the blood forward, the blood will back up and fill up the alveoli and the interstitial space, preventing gas diffusion from the alveoli into the capillary bed, and signs and symptoms will be reflective of decreased oxygenation and decreased perfusion. I would encourage you to look at each system and be able to give me a few examples of these changes due to decreased oxygenation in every system. Start from neuro. What happens in the head when blood is not brought to the brain? Changes in mentation from restlessness to all the way possibly coma. In cardiovascular, you have decreased cardiac output, you have decreased weaker pulses, you have increased heart rate, you have blood shift from the periphery to the major organs, so the cold, clammy skin. In respiratory, you have crackles, you have frothy sputum, you have decreased in O2 saturation, right? In renal, you see increase in BUN and creatinine, you see decrease in urine output. What labs do you expect the physician will order? Well, he wants to look at chest x-ray, which will show fluid accumulation in the lungs. He wants to look at ABGs and see changes in PaO2 or concentration of free oxygen in the blood, as well as SaO2, concentration of oxygen on hemoglobin. Look at carbon dioxide and bicarbonate to see if there is a respiratory or metabolic shift. Pulse oximetry will also tell us what the concentration of oxygen is. CBCs will help us determine if there is enough RBCs and hemoglobin to carry the oxygen. EKG, why do you think we will benefit from having an EKG, and what can that show us? Remember, when the heart is not perfused, the coronary circulation doesn't get enough oxygen, the cells become irritated, they may fire prematurely, the patient may go into premature ventricular contractions and ventricular dysrhythmias. What are some major nursing interventions? You have to assess the condition, definitely increase the head of the bed. That's like your first automatic reflex. Give oxygen based on oxygen saturation. Establish the lines, because you will have to give fluids, you will have to give emergency drugs. Connect the patient to EKG so you can check the EKG strip. Insert the catheter, because you will be giving diuretics so you can monitor the urine output, and then treat the underlying cause. What is it? If it's an MI, we will treat the MI, and we have already discussed that. Diuretics, vasodilators, inotropes are the drugs that we will be giving in this situation. Lasix, know the side effects, major side effects of diuretics. Vasodilators, that's your nitroglycerin and nitroprusside that will affect both the preload and the afterload. Give inotropes to increase the contractile force of the heart to be able to pull the blood into arterial circulation and unload it from the lungs. But that's your dopamine, that's your dobutamine, that's your milrinone, and we'll talk more about that in class. Cardiogenic shock is the result of pump failure. So the heart is unable to pump the blood effectively, decreasing cardiac output. And clinical symptoms, I think I have listed here on this little vignette, from tachycardia to increased preload to pulmonary congestion, decreasing cardiac output, everything that we have already discussed when we talked about an MI. Tests would be to check the blood pressure, because we know with cardiogenic shock, the pump is not pumping forward, so the cardiac output is decreased, the blood pressure is decreased. Chest x-ray, we want to see fluid, well, we don't want to see, but we will see fluid backup into the lungs. Blood tests will be looking at ABGs, metabolic panel, ABGs and CBC, echocardiogram, telling us if there is any valve prolapse because of the myocardial infarction, angiogram to see if and which blood vessel on the coronary circulation is occluded. Signs and symptoms listed along with hemodynamic what did I put here? Hemodynamic characteristics. So systolic blood pressure will definitely drop less than 85. In some books they say 90 millimeters of mercury. MAP will also decrease under 65. PaO2, pulmonary artery occlusive pressure, will be elevated, and that's the pressure in the left ventricle. Remember, in cardiogenic shock, the blood is retained in the left ventricle, unable to be pumped forward, so your PaO2, or the wedge pressure as we used to call it, will be elevated. But cardiac index, which is much better measure of cardiac output and proper perfusion based on total body surface area of individual patient, will be less than 2.2, meaning cardiac index is suboptimal. Respiratory alkalosis, we will see initially the patient will have respiratory alkalosis because he will try to compensate for decreased oxygenation in tissue perfusion, but eventually that will respirations will decrease and the patient will retain more CO2, turning metabolic status and respiratory into both respiratory and metabolic acidosis. And PaO2 will also drop below, and I'll talk about that. If it's below 60, that's really a bad sign. Treatments, again, we need to give oxygen, we need to give enough fluids to fill up the vessels and to maintain the blood pressure, and then we have to give medications, playing that tight balance between, remove some fluids and give some fluids. So again, diuretics, vasodilators, maybe even vasoconstrictors, and inotropes. That would be the treatment. If the patient is unable to benefit from these, then we can go into intra-aortic balloon pump, counterpulsation devices, and vascular assisted devices. And the goal, again, is to increase oxygen supply to the myocardium and decrease left ventricular workload. With this balloon inflation, and you see the balloon is placed right in that curvature of the main aorta. During systole, or the balloon is deflated, and that allows the blood to be pulled into the arterial circulation. The afterload is decreased. That will decrease the cardiac work, decreased oxygen demand on the heart, and increase cardiac output. During diastole, the balloon is inflated. It says here deflation. No, during diastole, the balloon is inflated, preventing any more drainage of blood into arterial circulation, but pushing whatever little blood there is in this curvature of aorta into the coronary circulation to feed the heart itself, to provide enough oxygen to the heart muscle. Complications could be mechanical problems with the balloon, impaired circulation, bleeding, and infection. And then, ventricular assist device is just device that we can use if the previous, treatments fail. So if we cannot improve the coronary circulation and cardiac output through IABP or pharmacological therapies and revascularization procedures, we may rely on the assistive ventricular assist device, and that's just the temporary measure because basically that's a pump sitting outside of the body doing the work of the left ventricle until the proper heart is found for heart transplant. Possible complications would be bleeding, tamponade, emboli, dysrhythmias, and infection. Cardiac tamponade, I think we've already mentioned it and discussed it. Causes can vary. Yes, it can be a result of an MI, but there are also infectious processes that can cause the fluid accumulation in the pericardial sac. I need you to be aware of signs and symptoms of that fluid building around the heart. So again, it's compressing on the heart, preventing it from pumping forward into the arterial circulation, pushing the fluid back into the lungs, then into the right side of the heart, then out into the venous circulation. That's why you're going to see jugular venous distension. Cardiac output will be decreased. Initially, the sympathetic nervous system will kick in by increasing the heart rate, thinking that it can compensate for decreased cardiac output. Because of the fluid accumulation, you will hear muffled heart sounds, shortness of breath because of the fluid in the lungs, and the wedge pressure of the left ventricle and the right atrial pressure will equalize. Okay.